Hello, in this lecture presentation we will discuss penicillins. Penicillins are active against a variety of bacteria. Their direct toxicity is low. The allergic reaction is the principal adverse reaction. You need to get that information from your patient to make sure that they have not had an allergic reaction in the past. With children, I usually ask the parent if they have had a anaphylactic reaction in the past, because I will then tend not to give it to the young child or infant if the parent cannot take the medication. The structure of penicillin includes a beta-lactam ring. This is what causes a problem with bacteria being able to be resistant to the use of penicillin. And that beta-lactam family also includes the cephalosporins. So what is the mechanism of action for penicillins? They weaken the cell wall of the bacteria, causing it to take up excess water and rupture. They are active only against bacteria undergoing growth and division, and they are considered bactericidal. There are some medications that are bacteriostatic, which only will stop growth, but these are bactericidal, which means that they will kill the bacteria. How is bacterial resistance acquired? It is the inability of the penicillins to reach the target, and they are usually because they are inactivated by bacterial enzymes, and they attack that beta-lactam ring. So those enzymes that attack the beta-lactam ring are called penicillinases. These render the penicillin inactive, and this bacteria can produce a large variety of these enzymes for specific penicillins, such as methicillin, and other beta-lactam antibiotics such as cephalosporins. So there are several classifications of penicillins. You have narrow spectrum penicillins that are penicillinase sensitive. You have narrow spectrum that are penicillinase resistant. You have broad spectrum penicillins and extended spectram penicillins. I first want to mention Pen G, which is bactericidal to many gram-positive and some gram-negative organisms, so not a true broad spectrum antibiotic. It is the least toxic of all the antibiotics, but is the most common cause of drug allergies. Let's talk a minute about penicillin allergies. It is really important that you assess every patient for a potential penicillin allergy, any reactions they've had in the past. Because when you're considering treatment for your patient, you then may have to look at another type of medication, another antibiotic to use to treat that infection. When you do your culture and sensitivity, if you need to, that will help you to figure out if there's another medication in some cases, depending on the infection, that you can use against that for that infection. If the history of the reaction is mild, you could easily then consider a cephalosporin if it is sensitive, if the organism is sensitive to a cephalosporin. But if there has been an anaphylactic reaction to penicillin, that you should not consider a penicillin or a cephalosporin. Now, there is a new trend of thought out there that there really isn't this cross-sensitivity to cephalosporins, but I would, in my practice, always err on the side of caution and not go with a cephalosporin unless the patient has a very mild reaction, or they say, well, I had a stomach ache or something that doesn't sound like a reaction. Maybe they took it on an empty stomach or something like that. I have also considered a third generation cephalosporin. If I had to give Rocephin for a more serious infection, I could I would consider that if the reaction to penicillin had been considered mild. But if it again, if it was anaphylactic, I would not even consider um, possibly using the third generation. I certainly would never use a first generation cephalosporin such as Keflex with someone who had a potential penicillin allergy, even with the change in the trend of thought. So the types of allergies, you can have an immediate reaction within 2 to 30 minutes, an accelerated within 3 days, and sometimes it's a delayed reaction. I've had patients who've maybe finished the whole course of a 10-day course of meds, and on that 10th day or the ninth day, they end up having their reaction. Of course, you don't want to have an anaphylactic reaction, and we all know that would be with laryngeal edema, bronchoconstriction, or severe hypotension, which could lead to death. So we really want to be sure that we don't put the patient in that kind of jeopardy. Drug interactions with penicillins. The main one you want to look at is probenecide. Has always been a reaction to watch for. You also want to watch for your book lists aminoglycosides, but that's because if you when you always give those in combination, especially in the hospital, you give Amp and Gent IV, but they're giving separately. You never give them in the same IV mix. So the theory there is that as long as the two aren't mixed together, there shouldn't be a problem. And the problem is that if the dose of the penicillin is high, it will decrease the effectiveness of the aminoglycoside. So here are our penicillinase resistant penicillins, which means that those enzymes don't work against them. And you can see the three that are listed, which are all IV medications, so we won't. Next, our broad spectrum penicillins. We have our aminopenicillins, which are our ampicillin, and our amoxicillin, which is widely used in primary care. Again, the more common adverse effects are rash, the penicillin rash, and diarrhea. And again, of course, we are hoping that we don't have that anaphylactic reaction. For extended spectrum penicillins, um, again, we're looking at an IV form, which would be the piperacillin. So again, we won't discuss that here because that is a hospital base and not used in primary care. You may send your primary care patient to the hospital to receive those, but that would not be something you'll be giving in your family practice settings. Then you have your penicillin combinations. And this is where you would add a beta-lactamase inhibitor, which would stop that enzyme that would make the penicillin ineffective. The most common one that is used, or the one that is used on with outpatient medication, would be the clavulanic acid. And if you look down on the slide, you'll see that the amoxicillin clavulanic acid is augmentin, which is used, of course, in outpatient settings. The other two would be IV, and again, those won't be of use in your primary care settings. But you certainly will consider augmentin for certain bacterial infections, some ear, skin infections, wounds, and things like that. So after this little overview, a patient with a history of severe anaphylactic reaction to penicillin has an order to receive cephalosporins. What should you do? And your answer, of course, is B. You would contact, if there's another provider, if it's yourself, and then you are alerted to the fact that your patient has had this reaction after you wrote the prescription, you would, of course, change to a different antibiotic for that patient and not a cephalosporin. That would not be appropriate either. Question 2, what statement about allergic reactions to penicillin does the nurse identify as true? And the answer is A, that anaphylaxis is more common with penicillins than any other drug. The takeaway here from the penicillin slides, I think, is that it's important to know, to be aware of allergies, but also to understand a little bit about the different classifications of broad spectrum, narrow spectrum, and getting a little bit of a handle on which organisms that are best treated with a penicillin product. And that's the end of this presentation. Thank you.